We're going to have really 8 different parts to this, which is why ortho, a brief history of clear aligners themselves. We're going to talk about an overview of the Candid Pro clear aligner system, what opportunities exist for dentists, general dentists in particular. Talk a little bit about the basics of occlusion so you can understand how teeth should fit and match and how they should work together. And then we'll talk about common types of malocclusion, bad bites, as we like to call them, how to diagnose those bad bites, and then we'll wrap up with a little bit of case selection. Take a peek at that. So to begin with, let's talk about the mission behind Candid Pro and clear aligner system that we developed. We want you to think of this as a big transformative change in oral health care. Originally when clear aligners came out 25 years ago, they were a disruptive technology, but they got kind of stale. I'll talk a little bit more about that. The goal of Candid Pro is to be able to change the way that we approach clear aligners in our patients and how we treat them so we can make it much more seamless, elegantly simple, and at the same time give us predictive results that we really want to see. So with that, let's jump in. Why ortho? I mean, why do we want to do ortho at all? Well, I want to start by just introducing you to a definition from FDI, the Federation Dentistry International, or World Dental Federation, as it's called, and discuss with you their new definition of oral health. I say new definition of oral health, it's actually 8 years old at this point. It was developed in 2016, but it talks about more than just holes in teeth or decay or pussy bleeding gums or periodontal disease, which is what we primarily think of when we think of health with someone. It really, if you take some of the keywords which I highlighted here and put them together from these 3 different bullet points, you end up with a really simple definition, and that is the ability to speak, smile, smell, taste, touch, chew, swallow, and probably most importantly, convey a range of emotions, because those are fundamental to the quality of life. So keep that in mind, and we're going to stack on top of it the World Health Organization. I want to talk a little bit about how malocclusion is a disease and how it plays a role in oral health. And you look at these 2 codes here that they use for it, and basically they both come down to the same thing: how the teeth touch, how the teeth match. If the shape of the arch, if the way they touch and come together, if the way you chew isn't normal or healthy, whereas atypical, then in essence, you have occlusal disease. You've got teeth that don't match and they're going to cause something to break down. So what types of malocclusion are we talking about? The stuff we see every day, we'll look more at this in detail. The stuff we see every day is crowding and spacing, open bites or deep bites, teeth that might be crossed over one another, which we call crossbite, right? Or even midlines that are off and things like that. So lots of different stuff. Typically, 3/4 of our patients have some sort of malocclusion in a typical GP practice. And the most important thing about this is that malocclusion is a progressive disease. I like to say that it starts off on like the bottom left and it goes up to the top right. So it's this kind of swooping curve that we see where things, when the teeth aren't lined up perfectly, start out as something as simple as the inability to really clean, brush, and floss well to keep the teeth in good shape. And then it progresses from there. Now, the thing is, it's most important, and I want you to keep in mind, is that we don't have to fix this. We don't. Mother Nature will fix it for us. And what I mean by that is if something is out of place or wrong, Mother Nature is going to find a way to make things as healthy as it can, Mother Nature can do, by shifting or adjusting, etc. So if we look at that progression, we can see it starts out as something as simple as poor hygiene, but then it goes all the way up to not just bone loss, but even jaw pain and breakdown of the joint itself, TMD and TMJ type issues, which obviously become expensive, serious in nature, and probably the thing that gets the patient in is painful, right? They become painful as well. So if we treat it on the bottom left, it's a lot easier than treating it on the top right, just like any disease with the human body. So if we look at this closer now, let's take a quick peek at this and look at malocclusion as a progressive disease. So I've got a really cool picture here of how teeth come together, right? And these teeth are not actually coming together the way we'd like to. They should have more of a vertical or axial loading force. When they have a sideways force, something's got to give. And in this case, we see that those teeth, because they're hitting on a little bit of an angle, cause the tooth to wear down in certain spots. It causes the tooth to flex a little bit. And when that flexure occurs, that causes a breakdown of tooth structure, a dissolution of enamel, as we like to say. And then the housing that surrounds it breaks down as well. I like to use analogies with my patients, simple analogies. And one I'm going to share with you now is my most common one. And that is that I like to think of a tooth as a fence post in the ground. If you think of a tooth like a fence post and you put force on that fence post, which is say up at the top, the weak point isn't up at the top of the fence post. The weak point is down at the base where the fence post comes out of the ground. And when you've got that flexure occurring, that bending moment, the pushing, the place where the breakdown occurs is right there at the dirt where it comes out. So say it's a wooden fence post, and if you flex that fence post back and forth, again, the top where you're putting all your force isn't really causing the trouble. It's the fulcrum down where it comes out of the ground. And that would result in the wood splintering if it was a wooden fence post, and it would result in the ground breaking down. That's exactly what happens with the tooth. That bending moment causes a dissolution of enamel, a breakdown of enamel. That's the little lower circle you see there where you see those chips kind of popping out of the tooth itself. And if that continues, you start to see the ground breakdown, which is the breakdown of the supporting structures, bone and the gums and the periodontal ligament that surround the tooth. They finally give up and they move away because the forces going sideways are too much. So a bending moment, we call that in physics, and that results in that loss of support for the tooth itself. So it's progressive. If you get it early and small before this occurs, you're in better shape. Let's talk a little bit about just a brief history of aligners, clear aligners. Kind of the coolest thing about this is that really the idea of some sort of alignment and aligners, came back around the American Revolution, right? Way back in the 18th century. So it's ages old, but we really didn't have any way of addressing it, of really kind of being able to use it to move forward. So we ended up coming up with the idea of putting brackets on teeth with wires to pull them back and forth. But it wasn't until the 40s, World War II, right? So a different war for America, but it was World War II that a guy named Kessling came out with the idea of using serial positioners to move teeth. And if you read his article, it's fantastic. He actually says, we don't have the materials right now to do what I want to do. But I got this idea that if I use a bunch of different things, I can slowly push the teeth instead of using these brackets that we put, these big metal bands that we put on teeth, which is what we used to do, is put bands on them and crank down a wire to pull teeth in different positions. It was painful and messy and bloody. It just wasn't pleasant. And then brackets came out after that, which we glued on the teeth, which were much better, but still not the ideal thing. And this guy came up with this idea of using it, but again, didn't have the stuff. Well, late 50s, early 60s, we finally had vacuum form type appliances, thermoplastics that we could use. And Nahom was the one who really said, let's look at using this to help move teeth. And he did it with elastics, etc. Jim McNamara in 1985 was kind of the lead guy. He's University of Michigan and one of the lead guys to look at using BioCurl polymers to help come up with the proper plastics to be able to move teeth using the BioStar machine way back then, which was a big advancement. And then in 93, Jack Sheridan came out with the idea of being able to use it as the Essex as a retainer and also to do IPR. He was really kind of big on using interproximal reduction to help make space. But it wasn't until the late 90s that we finally were able to realize Kessling's dream. So, half a century later, we finally came up with this way of being able to manufacture aligners in a streamlined basis and a mass produced and be able to change regularly, predictively, because we had digital, software that we could use to help figure out where we wanted to move the teeth, predictively go from start to finish. So it took a half a century for us to, again, take where Kessling started and get to where we in essence, finally were able to move teeth. Now, sadly, that's not where the story ends, because it then took another half of that, a quarter of a century, for us to actually make some serious advancements with clear aligners. It was disruptive, but we really didn't harness some of the great stuff that we had available. And I think because of that, the systems themselves got stale and we got used to using them. And now it's time to look at some differences. So when we talk about choosing a clear aligner system, let's look at some of the challenges that we have, like to get started. So the biggest one is like for a GP or student just getting out of school is like, where do I even begin? What do I do to kind of master this technique that they didn't teach me in school? And by the way, there's a reason that you didn't learn about ortho very much in school, and that is it takes a long time to do a comprehensive case, and really more time than they can teach you and you can learn in school itself. That pretty much kind of got debunked when we started using clear aligners. Now we could start doing cases at least and hand them off a little bit like we could a restorative treatment in dental school. But there still was somewhat of a stigma associated with the idea that you had to be kind of part of this little old boys club to be able to do ortho. And that's not the case. Anyone can do ortho. You just have to learn the right things and your skills, get them up to speed, which is what we're doing here. So you can begin. You can do this. It's not difficult. Do you need all sorts of crazy advanced training? No, not really. Do you need lots of different equipment? No, you don't need that either. You do need to train your staff. You don't need more staff. You just need to train them. You want to show them exactly what to do and how to do it and build it in just like you would any other procedure in your practice, from placing a composite to doing a prophy to doing endo or extractions, whatever it might be. So overcoming those things, those roadblocks at the beginning, not difficult at all. The bigger thing is confidence, right? Do you have the confidence to be able to do this? And once again, the answer is yeah, we just got to make sure we pick the right cases, right? Monday morning cases is what we want to do. We want to start with the basics. We don't want all sorts of crazy options and stuff that confuse us. And we want to be able to develop a good treatment plan. So we're going to work with identifying great cases. Options we need to keep simple. One of the frustrating things about one of the aligner systems that's out there is that they now have 23 different products, as they call it, products for treating teeth that don't move. That becomes a challenge because then it actually confounds your treatment plan, what you want to do and how you want to do it. Not a good way, so I'm going to share with you just a little cartoon here. If we walked up to the front of a plane, do we want it to look like the left side, which is kind of crazy with buttons and knobs and everything, or do we want it to look like the right side, just up and down? No, man, I need something that's designed for my needs, right? To fly a 777 right now, you're probably closer to the left side. To drive your Tesla in the auto mode down the highway, you pretty much have the right side, right? It's just, push a button and let it do its thing. Well, we actually are somewhere in the middle, right? What we need to do is have the right system designed for our needs, and we want it to be elegantly simple. I want to keep it as simple and as intuitive as possible and to guide me where I need to, but also let me make those important decisions to be able to move forward. And this is where a lot of clear aligner systems really fall short. They're, again, too complex, which becomes not very user-friendly. The learning is ridiculously expensive, anywhere between 2 and 6 or 7 grand. The learning curve becomes steep really fast. And if you don't have a lot of experience, then you end up with stuff that doesn't turn out the way you want to, and you end up having mid-course corrections and refinements and cases that don't treat out the way you want to. The opposite, again, the other side of that coin is that if it's really, really limited, you don't have a lot of options and you don't have a lot of capabilities, and therefore you got less patients that you can treat. And now there's generally no training associated with those systems out there. And once again, it leads to incomplete finishes. It, leads to outcomes that we don't want. So both the too complex and the very, very limited kind of take us back to poor outcomes. And that's what I want to get over for us. I want us to expect more. We want a system as dentists that is going to address the things that are important to us, and that's education, and being able to have the proper training. I want to have marketing that's built in and working for me. I don't want just, by the way, the marketing that appeals to, in some systems, the top 0.01% on like a doctor locator where you're never going to be able to compete. I want something that's going to be broad and more open. And if I'm going to have that, I better have the predictability, right? I better be able to get those outcomes that I promised my patients I'm going to achieve. To do that, I need to have really great control. And if I have those things, guess what? I got peace of mind. I can rest and relax and focus on some of the other things that are important in my practice. So this is where the cool thing about Candid Pro really jumps to the fore, and that is that it offers more. We have some fantastic education. We're getting started with it today. Again, and as you saw at the beginning, our orientation where we talk about our different levels of training, it's self-taught. You can learn it one of three ways. You can learn it live, like the traditional way at a study club or at one of the hotel banquet rooms where we have all day seminars. You can do it via webinar, or you can learn asynchronously with modules that you actually can take quizzes and get CE for. So really great clinical education. And the backbone of that is to have good support. So you need to have a way to get to that information and maybe someone to give you some guidance, which would be some of the account executives that we have or salespeople that can help get you where you need to go. And then they can bring that training to you also right in the office. So we can help train in your office to make sure that you've got all the systems down in place. You don't have to hire a company to come in to do this or have someone do half of it for you and still have to do others of yourself where you pay them all the profit you might make to do something. But if we have that, we again have to have the marketing support to get there. And we need to have some extra little tools. And probably the coolest and best one is this patient monitoring. So we're going to show you how that works. The patient monitoring and support for the patient circles all the way back to supporting you as a doctor. If we've got those things in place, we're going to be able to get that predictability we talked about and beautiful results. So let's look at opportunities for general dentists. Let's talk a little bit about that. We think of it, how often do we see stuff like this? Stop and take a breath and think of it. And I threw some extreme examples in here, but I threw some pretty much everyday stuff. How about the craze line in the bottom left, right? We see that. Or how about the deep bite in the top left? And the occasional open bite or the omega shaped arch on the bottom right. The idea is that we see all this stuff, including the last picture that comes up here, which is that one of just lower crowding. We see that all the time. And also confounding it, we see the fact that that patient had previous ortho, right? That second picture on the top right there, we notice that the bicuspids are missing, right? This patient had first bicuspids extracted because, again, with good intentions, we thought that there wasn't enough space for the teeth. Like the jaws had gotten smaller when really maybe the jaws had, but we need to grow the jaw. We want to keep all the teeth that we can to be able to accommodate the best bite and space for the tongue and all the other cool things that we'll talk about. The bottom line is, how often do you see this? Every day, every single day in your practice, you see this. You go over to hygiene, you'll see this stuff all the time. We're going to talk about an easy way to look at it differently and to address it. And I'm going to do it by using a really cool acronym for us, SMILE, SMILE. The idea behind this is next time you go into your hygiene room and you sit down to do your exam, I want you to think of SMILE, SMILE. And that is to first think about shifting or slipping. When a patient bites down, do the teeth come together evenly and stay closed? Or is there some shifting that occurs? The teeth slip over one another. Guess what? About 4 out of 5, 80% of the population has some sort of shift in their bite, maybe teeny. And by the way, we can learn to accommodate it. Remember, Mother Nature will overcome some of these things, but it also means that some things are breaking down to help make that all happen. So shifting is one. The next is malpositioned teeth for M. And then I is going to be incisal wear, looking to see how much those front teeth are wearing down. A really, really big thing to keep in mind. The next one is the lingual inclination. How do those teeth, when we look down the sides, how do they look? And then the last one is going to be enamel breakdown. So let's look at that shifting. And again, beginning back to our smile. Keep it simple. First thing we do is just say, "Hey, bite down for me." Have the patient bite down. And what do we notice? Do we notice that the teeth slide a little bit? Do we see where that might be associated with it? Do they all come together solidly? Or if you have them close slowly and they're biting down, do they hit, shift, and slide a little bit and close the rest of the way? And then for malpositioned teeth, when they smile, take a peek. Do they look like they all match properly? We know what matching teeth should look like. It should be a zipper effect. The hills and the valleys should fit together when we look at the teeth on the side. The fronts also should have a special way, and we're going to go over that. But I look and I see if they're malpositioned. That's a sign that there might be something going on. And then the incisal wear. How about this? You've had patients that have come in their 30s or 40s or 50s, and they say, "I've got brown stains on the top of my teeth." And the reason for that is that they've worn off all the enamel on that incisal edge, right? Again, simple analogies for our patients. My one I like to use when I'm talking about tooth anatomy is there's three parts to the tooth. There's the hard outer enamel. That's like granite, right? That's super hard. Inside, underneath that, is dentin, and that's like sandstone. That's softer and porous. And then very inside, what the patients call the nerve, we call the pulp. We know that that's arteries, veins, a lymph node system, and nervous tissue, all sorts of stuff that supports the living structure of the tooth itself. Well, if someone wears all the granite off that tooth, that soft sandstone becomes exposed. And guess what? That sandstone is porous, right? So it absorbs stains where enamel doesn't absorb stain nearly as much. So people will wear down their teeth and they'll start to see this brown appear at the incisal edge as it creeps up into the tooth itself. It becomes harder to fix the longer you wait. And sadly, we see some patients as early as 20, 25 years old that have worn down certain teeth, taken away all that enamel, exposed that dentin, and now it's not only exposed to stain, but prone to more breakdown as time goes by. And it's not providing the support that the enamel supports. So when we see incisal wear, that's what we think of. Well, what about that lingual inclination? If you look at this picture, the L and smile, look at how these teeth kind of come in, right? They all kind of cave in towards the middle. They're convergent, they tip in. And that's not a healthy thing because of the way the bite is designed for axial force, for up and down force. We'll talk more about that in a little bit more detail, but we want to think of the L and smile because it ties into the last one, which is E, enamel breakdown. When we talk about enamel breakdown here, this is again that fence post, and we think about the breakdown on the sides of the teeth or the wear that we'll see on certain cusps in the posterior, but it's the enamel wearing and breaking down, that granite no longer being there to give the support that the teeth need, exposing the dentin, the soft sandstone underneath, and causing more damage either on the biting surface or on the side, where, by the way, at the gum line, we know that that enamel gets thinner and thinner and thinner until it gets to the CEJ, the cemento-enamel junction, where the enamel stops and then the cementum picks up. And cementum, which is kind of like the type of enamel that you'd find underneath the gums, right? It covers the dentin, very, very thin, right? It's the difference between having, a 2-inch thick coat of plastic on the side of a house versus just a coat of paint, right? The cementum is very, very thin and can be scraped off pretty easily, exposing the dentin, which is why patients have sensitivity when there's sometimes root exposure, right? The cementum's gone after a little bit, and then the teeth become sensitive. So with that, we've got the smile thing down. Let's tie that into the basics of occlusion. We'll talk about bites. Occlusion is really nothing more than Latin for how teeth come together or match, to occlude, to bite. And when we think of that, again, super simple. I want to keep things simple for my patients and simple for you. So let's look at this diagram here that I'm bringing up right now. I'm going to talk about the three important things and that say that there's really just three parts. The joints, which act like a ball and socket, the muscles, which act like a sling to support that jaw, and then the teeth and how they come together. So you've got joints, muscles, and teeth. And if they all fit together and are in harmony, you have stability. But remember, we talked earlier about that shifting, slipping thing? If the teeth don't line up exactly right, Then now when someone closes down, they hit, they shift, they slide a little bit, and they close the rest of the way. If it's a teeny amount, we accommodate it. As it gets bigger, it becomes harder to accommodate it. When it's completely stable and things all match, we say that CR equals CO. CR stands for centric relation. And super simple again, centric relation is how the teeth want to close. Centric occlusion is how the teeth have to close. So you come down in centric relation, come down, the teeth are getting closer and closer and closer. Right when they touch, if everything matches, whoosh, they close all the way. If it doesn't match, centric occlusion, the way the teeth squeeze all the way together, will pull them into a certain position. They'll shift or slide to close the rest of the way. So again, CR equals CO means that everything matches. And if it doesn't, if there's a CR does not equal CO and there's a discrepancy, then we know that there's a bite that has some instability in it. There's some other terms that we use for this. CR is sometimes called the seated condylar position and all sorts of other terms. The CO, centric occlusion, is sometimes called maximum intercuspal position. That just means how the teeth close all the way, or MIP is sometimes the term we use for that. Bottom line is if everything's balanced, when they close down, everything will fit together. If it's not, you're going to, again, think a little bit about this, looking at this diagram here. If they're not, and the teeth hit, shift, and slide, if it's a little, we accommodate it, but if it's a lot, now what happens is you see how those muscles are coloring from different colors when they're active and not. One side, if there's a big shift, one side may be stretched and the other may be shrunken or compressed, right? Because the jaw's not hitting evenly and it's kind of out of whack. I always like to share what I call my soap bottle analogy with my patients because I started when I was teaching third-year students. I'd always talk about how I'd grab the soap bottle. It was right behind me when I was looking at the patient. I could grab it and I'd hold it in my hand and I'd say, look at this soap bottle. If I hold this right here, right in the middle, by my chest here, I can do that all day long, right? I can hold that soap bottle. It's comfortable, it's even, balanced. But what if I pull that way off to one side? How long can I do that for? Can't do it for long, right? Because one arm is stretched and the other is kind of compressed and shrunk back. It's not stable, it's not harmonious, it's not balanced. And because of that, the muscles now get inflamed on one side, compressed on the other. The jaw joint ends up suffering from this. Initially, it's just muscle pain or neuromuscular disease, and then it can get a lot worse as we go from there to joint itself breaking down. With that in mind, now let's jump into a little bit more on the basics of occlusion, and that is how teeth should fit together, right? We talked a little bit about this. Remember I said that thing about axial forces? We talked about how teeth should have an axial load on them. They should have a vertical force. There's a reason for that, that if they've got this vertical force, everything in your mouth is designed to support it. And not just everything in your mouth, everything in your body, right? The body is such a cool physiologic machine that every single part has this really, really cool function and this really cool purpose. And one of the things is that when we bite down, we should be able to, tear up food to eat. Our primary purpose behind all these things is to be able to eat that food and do it in the best way possible. But we don't just go up and down. We actually kind of go sideways, right? We can slide our jaw sideways, we go forward and back. You bite into a piece of corn on the cob and you slide your teeth forward, or an apple, or even a sandwich. So those forces not necessarily are always up and down, but interestingly, the body has figured out a way to accommodate it. So when we look at teeth, especially in the back, that are designed to take a load, you can see it's this vertical or long axis load. And if we look at now just a picture of a tooth itself, and we talk about how much pressure there is, it's amazing when we have this vertical load and we add the grinding component to it, that a tooth at the very tip is about 150 pounds per square inch. But in the periodontal ligament, it's near 500. And at the CEJ, remember we talked about the cemento-enamel junction, there's enough flexure that there's 750 pounds per square inch. And the bone, when we have this clenching grinding force, is again 10 times what it is at the cusp tip. It's 1500 PSI. Now, The teeth are designed to handle this. It's really cool. Look at the radiating dental tubules that come out there, and we think about the prismatic effect of enamel and how it's made to take that load, how the cusp tips are built up to certain ways to have everything fit together. Yeah, you can be a total dental nerd and look at a tooth and get excited, right? That's what us dentists do. And it's fascinating how it all works, right? How it fits together, and in it, someone with good dental health will keep their teeth for their whole life without any issues. But if you have parafunction, where teeth are grinding and not fitting together properly, and there's clenching and grinding, now we're going to multiply that force that you see there by anywhere from 3 to 10. So instead of 1500 psi of side force in the bone, you are looking at almost 15,000 psi loaded onto that bone. Well, guess what? Something's going to give, right? Something's going to break down. So we want to keep that grinding parafunction side force to a minimum because again, the teeth are designed to take that load, the way things swing back and forth. And if we look at this with a little three-dimensional picture video, courtesy of our friends at BiteFX, we can see that this is that fence post I was talking about, right? Here's that bending moment that's occurring. There's this sideways force when someone bites, they're biting straight down, but the tooth is not in the right position, so the tooth flexes. There's a bending moment associated with it where it comes out of the gums. And what happens? Well, two things. Again, the ground breaks down and the fence post breaks down. And we see that as this lesion that occurs. We used to think that abfractions were caused by brushing too hard with the wrong bristle toothbrush. And that probably accounts for maybe, I don't know, I'm going to say 2 or 3%, maybe 5 at the most, 1 in 20. But you know what really is the cause? This, an improper bite. And the best way to check this out, next time you want to, take a look at a patient who's got an abfraction lesion, got a little notch on the side of their teeth, and then ask yourself, why do they have it on tooth number 5, but they don't have it on tooth number 4 and 6 on either side? Are they just brushing that tooth too hard? Now, obviously, the answer is it's physics, right? It's a force that's applied to the teeth and it's improper. It causes that to happen. And sooner or later, by the way, Mother Nature will fix it by chipping, wearing, etc., until the other teeth can pick up this improper load, right? That's what happens with it. So the basics of occlusion is misaligned, breakdown. We start climbing that progression of disease that we said on the bottom left is small. As we move to the top right, it gets much bigger. So we want to address that and treat it as best as we can early. Let's talk about ideal occlusion. Okay, we've got now a good idea. So people say, Brian, tell me a little bit more about how this stuff should all fit together. Well, let's start off with the basics, and that is the arch shape, like how the arch should be a rounded kind of U shape that should be similar to a Roman arch. And if we've got that, there's enough room for the tongue. And if there's enough room for the tongue, we know it promotes a healthy airway. Something that actually is relatively new to not just healthcare, but dentistry and medicine in particular. Dentistry really started to embrace this long before medicine did. Not only do we want to have room for the tongue, but we want the teeth to fit together properly. So we want the proper amount of overlap and we want the amount of space up front there. And we'd like to have the teeth not rotated. They should, if it's an ideal arch, the teeth should all fit together without spaces or crowding, and they should all match up. If we think of this when we look at the teeth from the side view, this is the first time we're going to talk about this, but this is Engel's relationship, jaw relationship. And he really classified it into 3 different levels, class 1, 2, and 3, which we'll talk about in a little bit. But for now, as our first introduction to it, when we look at the sideways view, what we want to see in the molar region is that the mesial-buccal cusp of the upper first molar fits into the central groove of the lower first molar, that zipper effect, right? That hills and valleys all matching. And again, I'm really looking at 2-dimensional here, but teeth aren't 2-dimensional, they're 3-dimensional, right? So it's a true peak of a mountain or a hill fitting into the valley of the other tooth. And when you slide, it should glide. They should barely touch it because of there's other places that are taking up the load, the forces for that. So when we look at the side view, mesial-buccal cusp with the upper first molar fitting in the central groove of the lower first molar, zipper effect as we go forward up to the canines, which is the other place where we determine the class of occlusion is canine and molar, first molar class of occlusion. So when we look at it up at the canine, We now are talking about how the upper canine fits into embrasure space of the lower canine and the first premolar, right? It's the hills and valleys thing that we talked about. That's, again, healthy ideal occlusion. Taking a peek at from the front view, I'm going to think about aesthetic positioning now. Again, the cosmetic effect of how teeth should look when we think of a healthy smile. And that would be to have the midlines lined up, the top and the bottom midline lined up with that in the center of the face. More about that later, don't worry. But we also want to look at the arches being relatively straight across, right? Will have little ups and downs that we want that are natural. But when we look at the anteriors, they should be relatively straight, not canted on a slant in one way or another. And then a neutral overbite, again, a little bit of a gap. We're going to cover all this in detail, but you know what a healthy, beautiful smile looks like. When you look at someone's smile, you should be able to see just a nice, harmonious, again, somewhat symmetric, but not completely symmetric view of someone's smile. Now let's take that mouth and tilt it up a little bit. We're going to talk a little bit more about ideal occlusion, and with them tilted up, we now are looking at the overjet view of teeth. And with this, for an ideal overjet, we would like to have a little bit of freeway space. I want to have just a little gap between the top and the bottom front teeth. Some people would actually like to have them touch, but if they do, it's barely. They should barely touch, if at all. And the reason is as you slide forward into what we call anterior guidance, as you slide forward, those bottom teeth should just barely glide against the top teeth until you get all the way edge to edge. And then even the bottom teeth can go even more forward than that into a class 3 position. But when you bite down, they should barely touch. And interestingly, something really cool that you may not have been aware of is that the shape of the upper and maxillary incisors, central incisors, right, the upper front teeth, the shape of those actually mimic the shape of the articular eminence of the way your teeth fit together, matches the way your glenoid fossa is and your condyle. When you move forward, there's two different motions. There's a rotation and then what we call a translation, a sliding motion. But the important thing here is that that interior shape of the top teeth mimics that of the bigger version back there where the ball and socket is, so that when you slide forward, everything picks up the load. It's designed to pick it up evenly. Again, the cool thing about the human body and physiology. So now that we've kind of got an idea of what looks like a proper arch and how the teeth should fit together, let's go back to that thing about teeth not fitting together. Let's talk about common types of malocclusion. All right, you remember this slide? Let's dive deep into this. Let's take a little peek here. Before we do, though, I'm going to show you 4 other pictures. Why am I showing this and why am I saying this? Okay, so if I look at these 4 pictures of these teeth, they are not pretty, right? They are not, they don't look good. They don't look like all the stuff I just shared with you, right? They look crowded. There's a gap. They're worn, etc. There's a deep bite. They are not pretty by any means. But interestingly enough, they're happy. And what I mean by that is that Mother Nature has fixed the problem as best as Mother Nature could to get everything to fit together in a comfortable state for this patient, for this, this person who's got this bite the way that they do. Now, it's not ideal by any means. It's not even close. And they probably have some symptoms that we'll look at and signs that are associated with this type of bite. The reason I share this with you and why this is so important is that I don't ever want us as doctors to take something like this and make it pretty but unhappy. Meaning I don't want to move the teeth and give them that, that happy smile, Hollywood smile, with all sorts of crap and wreckage going on in the back of the mouth, or even the front of the mouth that we can't see because it's where the teeth cover each other. So take-home message here is they're not pretty, but they're happy. I want to make them pretty and happy. All right, that's got to fit together. And if we do that, do our goal right, they're going to want to stay, right? Because that's the beauty of human physiology is if we do it right and it looks right, there's a reason because everything fits together and runs in harmony. So that's our goal. Enough of this not pretty but happy and pretty and unhappy and all the other stuff. We're gonna get to both pretty and happy. And to do that, we're gonna learn a little bit about the common types of malocclusion. We're gonna start with the one that you're going to see the most in your practice 45% of the time, just about half when someone comes in hygiene and you look at them, they're going to have some sort of crowding for a malocclusion. Generally, we'll notice that it's the lower teeth first that we see that are crowded. And the way that that happens, by the way, is something called mesial drift. It's the tendency for teeth to want to bunch up in the front of the mouth there. We can get into the anthropomorphologic reasons for this. It's a really cool thing, but too much for us right now. We can do that in a third level course. For now, we're going to talk about the fact that we know teeth move to the midline. We used to even say, hey, take out the wisdom teeth, and they'll stop doing that because the wisdom teeth are pushing them forward. That's a bunch of baloney. That doesn't even have any, no, that's baloney. So let's cut that one out. Wisdom teeth in or out, you still get that movement towards the middle, mesial drift, and it exacerbates itself. It shows itself as crowding down in the bottom. Teeth get all jacked up down there. And guess what? Another analogy for you. Teeth fit together like a lid and a jar. Bottom is the jar, top is the lid, and everything should fit in harmony. The lid should fit just over the jar. Well, if the bottom teeth are all crowded, guess what? They put pressure on the top teeth and crowd those as well. It's one of the reasons why you can't treat just a single arch almost all the time when you do ortho, because if you fix just a lid and not the jar, they don't match. One gets pushed back the other way, teeth go off track. So crowding, again, being about half the cases you're going to see, typically occurs because of mesial drift. We see this in particular with our adult patients. The older they get, the more crowded their teeth are in the bottom, the messier it looks. We can address that. We can fix it. So when we think of crowding, what are the issues? Well, to start with, an improper ability to chew, right? Bad occlusal function. And that will show up by wear on teeth in certain areas, recession, bone loss, things that are breaking down throughout the mouth. And it leads to the symptoms of sensitivity to hot and cold, rough edges, right? Teeth that actually can become loose and gums that recede, all associated with crowding, which is going to be one of the most common. Now, the next one that we're going to see, probably the most of, is spacing, right? The opposite of crowding is crowding's too much tooth mass for the amount of arch space. Spacing is not enough tooth mass for the amount of arch space, and we see two different types here in this picture. We'll talk about that in just a second, but let's think about some of the issues that happen when we've got this spacing issue. Well, we typically don't have proper support, and we now lose some of the important guidance when we slide sideways, both canine guidance and guiding up off the picking up a little bit on the anterior as we move more to an anterior guidance, protrusive as we call it, but not having guidance on the little laterals, which are weak teeth. So we have kind of an improper way that the teeth can slide around one another. And that, again, can lead to premature wear of the teeth, gum problems, et cetera, associated with it. One of the things that patients will notice is that the teeth will flare out to try and fit together. Now, the reason that I'm showing these pictures on the right side is really important. That the top one, we see spacing, but it's really kind of just between the two front teeth. And that is a diastema. We call that, space in the front, a diastema. But we don't really see a lot of spacing anywhere else on the top, and we don't see any spacing on the bottom at all. Well, that is a lid in a jar that's already fitting together pretty tightly, right? When you bite down, all the teeth are touching, there's a gap. So if you close the gap by making the lid smaller, the only way you can do that is to make the jar smaller. Otherwise, you can't make them fit. We'll talk more about this in detail, but it's one of the things that I just want us to pay attention to, because if we look at the bottom picture, we see spacing in the top and spacing in the bottom. I can manage and control that because I can make the lid and the jar both smaller together and make them fit together proportionally and make sure that things fit harmoniously when we're all done. So again, looking at this, we're going to pay attention to the amount of spacing we have and where it's located. All right, next one we're going to think about is an open bite. That's where we have a gap. Typically, if it's up front in the front teeth, I generally look at that as, usually that's a developmental type issue, either a habit or possibly something that might have been developmental. But oftentimes this is like the top picture you see there. That's the result of a kid sucking a thumb or having a nook or something in there way too long to help create that space. It creates a big issue with the lack of function, the lack of good anterior guidance. It loads up the posterior teeth and causes them to break down because we don't have, again, good distribution of forces. And then that leads to the trauma that you'll see with the typical just breakdown in the occlusion, recession, bone loss that follows it, all the things that we don't want. Patients will notice the wear. They'll notice notches along the gum line in the back teeth in particular, and oftentimes have some sensitivity associated with it. The bottom picture you see is a posterior open bite. Different issue, almost always iatrogenic in nature, caused by something that was done in dentistry. Not always, but again, I'm going to say 95% of the time we see posterior open bite. There's a reason for it, generally related to dental procedures. And we'll talk about that and how to fix it a little bit later on. What about that one that's kind of halfway between the crossbite? Well, again, something that is going to result in patients noticing that they're grinding their teeth, the wear isn't proper on them, the jaws don't fit together right. They sometimes end up with asymmetry and even joint issues or pains, jaw pain or headaches that's associated with it. But the big thing here is an aesthetic issue where the teeth just don't look pretty and don't match together. We'll talk about this in more detail, but anterior, which we see here on the top and on the bottom pictures, not so difficult to treat. Generally, we say that that's a dental crossbite as opposed to a skeletal, meaning bony. And a dental crossbite, easier to treat. Removing teeth, it becomes a little bit more simple for us to address. Skeletal crossbite, much more challenging. And again, we're going to kind of keep in our lane. So we'll talk about that a little bit later on too, which leads us to the opposite of open bite now is deep bites, right? So a deep bite is where there's not enough teeth in the bottom showing. There's too much overlap there, and that can result in improper function, especially with the anterior teeth causing wear and also causing, believe it or not, jaw issues at some point down the road. But we'll also see receding gums associated with this. The teeth may be mobile, in particular incisal edges get kind of sawed down, not so good for us. What would be another thing that we might encounter, more rare? You can see we're kind of getting a little bit more rare as we go along here, and that is class 3. It's where the bottom teeth are in front of the top teeth. Like to say the bottom jaw is too far forward, the top teeth are too far back, one or the other. The big thing about that is you can have some abnormal tooth wear and pain associated with that. Patients oftentimes have difficulty opening and closing properly because their jaws is somewhat pulled forward oftentimes, unless it's that's a dental issue, or sometimes it's a skeletal issue. We may have to do some sort of surgery, orthognathic treatment to be able to correct it. It also can lead to difficulty with chewing and speaking, the muscles being constantly sore, headaches that could be associated with it. Things that patients will come in and talk about is that, gosh, I just can't chew and function. I've tried for years to be able to do that. With that, let's jump into diagnosing this. Now, how do we diagnose malocclusion? Well, let's keep it super simple, and let's just go to basically our 3 different planes. And by the way, these are the same things we use in geometry and calculus and flying airplanes and everything else, right? We have our sagittal dimension, our vertical dimension, and our transverse dimension. Sagittal is kind of the front back. So we're looking sideways, moving teeth front back. Vertical is up down. And then transverse is like looking from the roof of the mouth down on the teeth, or looking from the tongue up. That's transverse is in, out. All right. So those are the kind of the 3 different dimensions. Let's start with the sagittal, the forward and backward, and talk a little bit about those angles, classification of occlusion that we touched on earlier. So class 1, as I described, is that mesiobuccal cusp of the upper first molar fitting into the central groove. And then a zipper effect as we go forward, the hills and the valleys all fit together. When you slide sideways, they slide through one another. Again, one of the cool physiologic things is that we slide and the load is picked up sideways in the right spot with the canines actually doing most of the work there. Class 2 is where the top teeth are too far forward or the bottom teeth are too far back, and you have sometimes a gap that's associated with that. Class 3, just the opposite. Bottom teeth are too far forward, top teeth are too far back. The best example for Class 3 is Jay Leno, the comedian and night talk show host. Severe Class 3, his chin comes in the room before he does. And big pronounced chin that's typically associated with that, and usually a similar bite that's associated with that. Guess what? Class 1, 2, and 3 can also be broken down into healthy and unhealthy. And this is something that I want us to keep in mind. So when we think of Engel's classes of occlusion, we used to think, oh, class 1 is healthy, class 2 and 3 are not healthy, they're unhealthy. But we saw from earlier both the FDI and the WHO definitions and coding of malocclusion that it's not that. It's not the classification via Engel's method of how teeth fit together. It's how teeth fit together. And you can have class 1 that's diseased, and we'll look at that. And you can have class 3 that's healthy, that the patient functions okay, and maybe the best thing to do is leave them. And I think if you ask Jay Leno, who's in his probably 70s at this point, that he's lived with that since he was 12 years old, maybe even younger, he's done all right. And maybe we don't want to touch it. So keeping in mind, healthy and unhealthy, let's take a peek. So here you've got a picture of class 1, healthy occlusion on the left, and a class 1, right? We still got the teeth all kind of matching up right there, but it's unhealthy. It's a malocclusion. And the reason is we've got some crossbite action going on there. The teeth aren't exactly in the best place, but the hills and the valleys pretty much line up, and we should be able to get those guys to fit together properly. Before we jump ahead, I'm going to take a peek back on the left side, because one of the things that helps to make this fit together properly is that there's a teeny little space just behind that upper lateral number 7. You'll look at the back side of it, there's a little gap, and that's Mother Nature accommodating things to make it fit together properly for a healthy class 1 relationship. It's more of an aesthetic issue, the fact that there's that little gap there. And the reason that there's that little gap is part of the evolutionary trend of our laterals being smaller in size, something we routinely see, especially compared to jaws just 300 or 400 years ago. We'll notice a difference with that. Again, stuff for anthropology later on, but for now, noticing that there's a gap, aesthetic only. If it really bugged the patient, the best solution would be to do a little bit of bonding there and fill it in. The other way to fix this would be to, if the patient says, I want to close it and I want to use ortho, you would have to do some reduction of the lower arch, because the lid and the jar match really well right now, and we need to make the lid smaller, right? If we make the lid smaller, we got to make the jar smaller. We got to do some IPR, some interproximal reduction, to shrink those teeth. Not such a good idea, right? We see this and it's all fitting together. Not such a good idea. This is a restorative solution, not an ortho solution. The right side, different story there, right? We can see we definitely benefit from putting those teeth in a better position orthodontically. Super great, easy thing for us to accomplish with clear aligners, but not necessarily a Monday morning case, because there's a little bit going on in the posterior that we want to get our hands on. We'll talk about that a little bit later on, but let's talk about class 2 occlusion now. Class 2, bottom teeth too far back, top teeth too far forward. We can break this down into a couple different types. One is called division 1, and the second is called division 2. Division 1 is typically the teeth are flared out. They got the buck look. The teeth are sticking way out there when they smile. Class 2 Div 2 is also a really kind of obvious thing that we look at and see, and that's where the laterals are flared out and the centrals are in. Somewhat of kind of that bunny rabbit type appearance there. There's a reason for that, and that's physiologically teeth want to touch. So this allows for some teeth to touch together when we have that. It's just a coupling effect that we have with teeth. And in order to get those jaws to come together as best as possible, the laterals have flared out and the fronts have come in to help provide some support. We can also look at class 2 and class 3, but we'll talk about class 2 in particular. We can also look at it as how the cusps touch. So if they touch right on top of one another, we call that a half cusp occlusion, meaning that the teeth are shifted back a half of a cusp, which is about a quarter of a tooth, right, to get things to match. Very unstable. You can see the hills are hitting the hills, the valleys are wide open. I routinely say, I don't mind if someone comes into my practice like this and we leave them that way after I've educated them on why it's not healthy. What I don't ever want to do is take someone from a full cusp occlusion and put them into a half cusp occlusion, because it means there's going to be a lot of breakdown down the road. The other one you see on the right side is a full cusp occlusion and class 2. In this case, the teeth are back a entire kind of half of a cusp so that they fit together. Hills and the valleys somewhat match, but the teeth are shifted back, in this case on the bottom, by a significant amount to allow for that the hills and the valleys to match. Class 3 we've covered. You can see these examples here where the bottom teeth are too far forward, top teeth are too far back. Sometimes this is a dental issue and can be addressed. Other times it's skeletal. For those of us just getting started, we're staying away from class 3s right now until we've got a much better handle on what we're doing orthodontically, how we're going to accomplish it, and what may be necessary to bail us out if it becomes a challenging case. Okay, let's jump on to vertical dimension now. Vertical dimension, up, down. Remember, that's going to be looking at teeth in an up, down, or axial orientation. So when we talk about that, first thing we're going to talk about is overbite. That's the amount that the top teeth cover the bottom teeth. So when we look at overbite and measure it, GPs typically measure it in millimeters, while orthodontists measure it in percent. So me as a GP, I'd look at the teeth on the far left side, and I would say that those have about 1.5 to 2 millimeters of overlap there. The middle yellow one that we see, that's got somewhere around 3 to 4 millimeters of overlap. And then the far right, I'd say that's maybe 7 millimeters of overlap, 6 to 7. Well, an orthodontist is going to measure that in percent, and they'd say that normal is 10 to 30, and somewhat abnormal is 30 to 60, and then anything above 60 is severe, so 60 to 100, but in essence, that could be more than 100, because when they measure percent, they're measuring the amount that the lower teeth, the incisors, the lower anterior teeth, are covered by the upper teeth. So the one on the far right, in red, those teeth are covered about 85%, 80 to 95%, but you could actually have greater than even 100, because you could have those tops covering the entire tooth and then some, where it actually covered the gum. And typically you'll see in those situations with the very, very severe class 2 that the teeth which want to touch are actually touching on the palate of the patient's, the upper arch, or touching the soft tissue. So we think about vertical dimension. Let's stay on the overbite thing and look at how we can associate the different types of malocclusion associated with it. Well, you could have an open bite, right? You could have edge to edge where the top and bottom teeth actually touch, something that patients often think they're supposed to have. They don't realize about the lid and jar that you should have an overlap, right? They think of them that they should touch. And you get a moderately deep bite or a severe deep bite. Again, that far right picture, we look at that, that's 95 to 100%. That's almost completely covering those lower teeth, right? That's one of the things that we want to pay attention to. Once again, I will remind you that teeth generally want to touch. They want to touch when you bite down, up and down, and they like to touch sideways too. That's why teeth will typically drift to close any open gaps. Not always, and again, that's a anthropology thing, a physiology thing that we can talk more about later on. But for us to keep in mind that in the far right case, probably those lower front teeth are touching on the soft tissue on the palate of the upper teeth there, because there's no stop on the teeth themselves, and they've just basically kind of continued to move until they find something to tell them to stop and stay there. Okay, that brings us to open bites, right? We talked a little bit about this earlier. Anterior open bite, typically a developmental type issue. Oftentimes you can see it might be associated with airway too, and breathing. You can kind of look at this guy or gal and bet that they're probably a mouth breather. just because the archway is narrow and constricted, the tongue's probably pushed back. We look at the picture on the right now, and what we see is the teeth don't touch in the back. That almost always is associated again with some sort of dental abnormality of one sort, again, actuated and caused by a dental treatment of some sort as well. We'll cover that in detail. Oftentimes people say, oh, it's due to the thickness of the plastic when you wear clear aligners. Almost never is it associated with that. That was something that we used to think a long time ago. It doesn't have to do with that. And again, we'll cover that in detail a little bit later on. More importantly, we're going to look at how the front teeth are touching, because in this case, the picture on the right, they're really kind of getting crushed by the bad bite that's caused there. Edge to edge, again, oftentimes patients think that that's how teeth should touch. They shouldn't. There should be that overlap. And when there is that edge to edge, remember we talked earlier about wearing down all that enamel, taking away the granite, exposing the sandstone, causing stain. You can see that that is the case, in particular with the middle picture there. But if you look at the right picture and you look at number 8, which is the left incisor, upper incisor in our screen there, you can notice that you can see that little brown edge along the incisal there going up about 2.5 millimeters. That enamel has worn off. There's exposed dentin, and that's the classic stain that you'll see associated with it. You don't see it on the right because that's bonding or a veneer or crown or something. It's some sort of artificial structure there. But that's typical of what we see when teeth are wearing on the edge, and they shouldn't be. Brings us to the last different plane, different dimension, and that is transverse. So when we think of transverse, that's the in-out, right? Looking down from the roof or up from the tongue and looking at the arch and thinking about how we want to move the teeth in and out. And in particular, there are 3 things I want you to pay attention to. This is key to when we see crowding, and that is if the arch form, arch width, or buccal lingual inclination is not proper, typically we're going to see crowding associated with it. So let's start with arch form. The arch form, as we mentioned earlier, should be a U shape. It should be a nice, broad U-shaped arch. It allows space for the tongue. It allows for all the teeth to line up, everything to fit together. It looks normal and healthy. What else is there? Well, there's the V-shaped arch, right? That's the one where typically, again, that's been oftentimes from a habit, a thumb pulling those teeth forward. Sadly, that's not just the teeth that are pulled forward in a situation like that. That is a displacement of the premaxilla. The bone up in the front has been pulled into this funky shape slowly over time to create this long, narrow arch that's not healthy. Square arch, typically that's going to be associated with that class 2 div 2 that we talked about. And then omega arch, that's when someone smiles and you see some front teeth and then you don't see anything. And then you see back teeth. It's omega after the Greek symbol. And it looks like that kind of, weird, I think Lululemon sign or whatever it is. But the idea is that we don't see bicuspids when someone smiles. They're hidden because of the way the arch is shaped. Again, no space for the tongue in a situation like this, and very unhealthy. It leads us to arch width. So we know that if it's a healthy U-shaped arch, it should have a certain width that's associated with it. And that typically always was measured at the canines from cusp tip to cusp tip, which we call the intercanine width, or from the molars, the first molars, measured at the fossa, the central fossa of the upper maxillary first molars. And if we measured that, we could get, again, some pretty good data on what's going on. Well, Jim McNamara, again, the guy from University of Michigan, a long time ago, came up with a better measurement, which actually makes more sense. And that is what is often called the transverse measurement, or McNamara measurement, as it often is called, which is the distance between those upper first molars, but is measured at the most lingual part of the tooth. So usually it's the crest of contour on the lingual of these upper molars, and that we're going to measure there and figure out what that space is. That space typically should be somewhere between 35 and 39 millimeters. If we've got a transverse measurement that's there, typically it means that the teeth are in the right position and they're lined up. You can see here from this picture that I've put in here, we just took a Vermeer caliper and dropped it on there and just on this dentiform, right, and measured it, and it came back at just under 37 millimeters. So it gives us an idea of what even a typical normal one should look like. We can do this in the mouth as well, but it's certainly hard to get a Vermeer caliper in there. So let me show you a really cool little trick. If you use a cotton roll that's on your tray already and hold it up there between the first molars, that they typically are around 38 millimeters. You'll have to measure yours and see, whoever's making them, what their length is, but generally they're around 38 millimeters. So before I even get started with new patients, oftentimes when my assistants are grabbing records, they'll go ahead and just grab that little cotton roll, fit it up there. If there's space on either side of the cotton roll, it means that they've got a super healthy, kind of nice, normal arch, and it's in good shape. Most of the time we see that that's narrower, that it doesn't completely have the width that's necessary for health, for good health. So cotton roll trick, we like to call it, works great for our transverse measurement. You can look at these photos now and you can see that healthy, again, far left. And as we get more narrow, things get more funky down to that V-shaped bite. Brings us to the last part of the transverse dimension I want us to pay attention to, especially with crowding cases, and that is the buccolingual inclination of the lower teeth, posterior, the bicuspids and the molars. When we look at the buccolingual inclination, we like to see that there's very little difference between the height of both the buccal and lingual cusps on these teeth. If they're relatively even, then we know that the tooth is probably vertical or axial in its presentation, and it's going to be able to absorb the forces as the best as possible. So here we're looking at, again, just a ruler on a dentiform model, and that patient we saw previously with the cotton roll is here again. This is Morgan, our wonderful assistant, who's got a pretty smile, and we go ahead and drop the ruler on there. You can see that both the buccal and lingual cusps of these lower bicuspids are pretty darn even, meaning that the force going up and down is a nice axial or vertical force and helps to distribute things well. So what are the credentials for a good, healthy occlusion? Well, we want the proper arch form and arch width. We want to have proper buccolingual inclination, meaning relatively up and down for those bottom posterior teeth. The top will follow, obviously. We want to have proper overbite and overjet. Remember, we said just a little bit of a space when the patient bites down all the way. Shim stock space is typically what we say when we're looking at that. And then for overbite, yeah, 1.5 to 4 millimeters, usually somewhere around 2 to 3 is ideal. With the back teeth, we want to have posterior cuspation. We want the patient bite down and have the hills and the valleys all fit together. And then when the patient slides, they don't touch, they come off. We also want them, when they close down, to not have any interferences, because that, again, is something that helps to push the teeth or the jaw in the wrong direction. If we've got things fitting together pretty well in the back, when they slide sideways, the patient will glide off their canine and not have any other teeth touch. That's called canine guidance or canine protection. It's very, very important for the long-term health of your teeth. What happens as you get older is you slowly lose canine guidance, and it oftentimes gets picked up with what we call group function. And group function is where when a patient slides sideways after having bit down all the way, a lot of teeth on one side will pick up the load, and that's because the canines have worn down over time. Last thing is that we want to have anterior guidance with posterior disclusion. That means when they're going for that corn on the cob movement or sliding the bottom jaw forward, as they do that, the back teeth should all come apart. Nothing should touch. That's called posterior disclusion. Super important for being able to keep things healthy, not have them break down, right? We don't want those cusps to break down. Okay. So ideal then, to me, would mean healthy. I want a nice healthy smile. I want it to be stable so it doesn't move or break down. I'd like to have it function properly. We just talked earlier about how the teeth need to fit together properly to do that. If they are, they'll almost certainly be comfortable. And then all those things put together equals an aesthetic smile. Like when we look at a smile, we apply all these different formulas to it and data. But sometimes we just look. We look at the woman on the right-hand side there, like, yeah, she's got a pretty smile, right? Things may not, for every single person, figure out the exact same formula. As a matter of fact, we don't want that at all. We do want someone who's got a healthy smile that looks pretty, and we know if it's that, it's going to be stable and she can eat well, etc., associated with it. So let's keep those things in mind and jump right into a case selection guide and think about some of the things that are important for us. We talked about our angles classes of occlusion earlier, and I said that is not where I want us to determine malocclusion, but it is something I'm going to use as a guide to keep us out of trouble. Class 1 cases, if there's a malocclusion, you can treat almost all of them, because to begin with, the hills and the valleys all match, they touch together and fit nice and tightly, and we're in great shape when that occurs. And it's easy for us to address crowding or spacing, et cetera, associated with that. Class 2, bottom teeth are too far back, top teeth are too far forward. We could treat some of those, in particular if we're going to leave maybe a half cusp occlusion after having educated the patient about it. We've seen that they've got a class 2 relationship. The teeth are half cusped, the hills are hitting the hills, and we tell the patient, I can't really move this entire set yet. I need to get some more cases under my belt. I can definitely straighten them out, but I'm gonna have to leave that somewhat the way that it is. The patient says, fine, go ahead. Class 3, much more challenging because this is an orthognathic type thing, and unless you're doing a lot of orthognathic cases to begin with, it's something that I'd prefer for you to just leave until you've got better skills underneath your belt. So those colors all translate into a stoplight. We like to kind of think of it as what's the everyday, what's the advanced, and then the red, it says ortho referral. It just means, it doesn't mean you can't do it. It just means you got to have a lot of skills underneath your belt before I want you running that red light. So things that do work for us is to correct midlines, intrusions, and extrusions. Basically, with plastic only, we can move any tooth about 2 millimeters safely and comfortably. For overjet and overbite, that would be 2 per arch, right? So that's 4 millimeters. And then if we take that transverse view, we're looking at spacing and crowding, we can deal with about 6 millimeters total of that. Now, for rotations, if you've got a tooth that's rotated, we're thinking of somewhere between 20 and 40 degrees, or maybe even 45. Think of it as about an hour on the clock. That's 30 degrees on a clock. Well, if it's a molar posterior tooth, it's very difficult to rotate, not just because it's a big boxy square tooth, but because it's got 2, 3, or 4 roots that are pinning it down, holding it in the bone. Remember, that's where we do a lot of our chewing and grinding. So it becomes kind of important that we consider how much we can rotate as we move forward and get closer to the front. Once we get up to those lower incisors in particular, I can rotate those guys 45 degrees. I'm not worried about it because I know that if I have really good records, I can put plastic right over those teeth and now go ahead and provide some twisting force and rotate that, spin it like a top, using all that big flat surface area to help accomplish my goal. Oh, the other thing that's an everyday thing is for us to treat anterior cross bites. Love doing that. I think clear aligners are much better, safer, and more aesthetic for patients than trying to do it with fixed ortho. And with that in mind, anterior, okay, posterior, yeah, a little more challenging. So if you have some advanced skills, go for it. You can go ahead and do molar cross bites with clear aligners. You just want to make sure you pick the right cases. Speaking of, that would mean mixed dentition as well, or patients with TMD or TMJ issues. If you understand and treat TMJ on a regular basis, you can definitely do it with clear aligners. It's a great way to do it, but it gets more challenging as the case gets more complex. So keep those things in mind. Finally, stuff that I prefer for you to send out, at least initially, is class 3 cases, surgical cases that might be an orthognathic type case, and then finally any ones that have complex movements, maybe multiple movements that are more of a challenge. Let's talk about some cases that we can treat Monday morning in our practice and ones that we might want to stay away from. We're going to start by thinking about transverse and moving in that plane. When we look at our first case here on the left, we've seen this picture before. Is this a good Monday morning case for us? And the answer is, yeah, we could do this. This is a lingual inclination case. So we're really looking at moving teeth out and straightening them up. They're already tilted in, so it's more of a tipping type movement, which we'll talk about in a little bit. Definitely a Monday morning type case for us. I'm excited and willing to jump in Monday morning on that. The middle one, we see crossbite there, and it's more than just one tooth. It's 3 teeth, but they're all in the anterior, and a little bit more of a challenge, but I would definitely send this one in and have it managed. I know that there's class 1 occlusion associated with this case. I'm feeling that all 3 of these teeth are, again, dental in nature, not skeletal as far as the crossbite is concerned. And it's something that is better treated with clear aligners than it is with fixed ortho in a situation like this. So this is definitely an everyday Monday morning case. What about this one here on the far right? Ooh, a lot going on there. There's molar crossbite there, so I'm going to want to stay away from that. There's canines that need to come down a whole lot vertically, much more than the 2 millimeters that we talked about. Is this a case that I want you to do Monday morning? No, it's not. But once you've got some skills underneath your belt, this is a case that you could definitely treat with clear aligners and end up with a nice result. I just want you to be able to have good management skills, so not something we jump into right off the bat. Let's look at some other cases. How about this one on the left here? Well, sure, that's a class 1 case with a little bit of crowding and a little bit of a deep bite. Monday morning, jump at it, go for it. That's nice and fun. What about the middle one here now? We see that there's spacing on the top and the bottom. We've seen this one before. Easier for us to do because we've got spacing that can pretty much match itself in both arches, and we can go ahead and fix it. A little bit of a crossbite on the bottom there, too, that we're going to be able to help get into place. I'm pretty confident we can do a nice job with that. And then the last picture, all right, there's that diastema we talked about. All the teeth are tight down in the bottom, no space, but there is that gap up top. The only way we can close that gap up top to squeeze those teeth together is to make the less enamel on the bottom to actually take away some tooth structure via IPR in order to get those teeth to close. So you want to think about how you want to manage that. Can you do it? Yeah, you can. A little bit more of an advanced skill set for us, but maybe you want to do it by moving the centrals together, leaving a little space by the laterals, doing some bonding then to get those back to the proper size, or maybe veneers, etc., and not doing any IPR on the bottom, which is the way I'd prefer to do it. Okay, let's talk about vertical now. Well, that's the up and down, right? What about this one? I see that there's, oh boy, that's about 85% on that one too, 90% on the other one. Man, that's a lot. Okay, can I get those teeth down 2 millimeters in each arch and end up with something that'd be better? Sure, that's a Monday morning case for us. We can help line that up and get that looking much better, to get those teeth fitted together properly and manage that bite. Something I'm happy to do. What about this next one? Well, that's an open bite, and I see about 3 millimeters of gap there. That means I'm going to want to get that closed, say 4. Well, that's just inside my range there. I think I could do that, but that's more advanced. We're gonna get some cases under our belt before we do that, because we're gonna upright these arches and end up with some spacing that would be associated with it. We can manage all that, but again, a little bit more advanced for us. How about this next one here? Well, you know that this is arches that don't match. This is a significant sagittal changes that we need to accomplish here. You can't just correct this vertical by trying to, again, pull teeth into a different position. This is the top and bottom arches don't look like they match together. So how about sagittal? Let's talk a little bit more about the back and forth. Well, the first picture on the left, that's a class 1 case with no AP correction. Monday morning, super simple type of thing. What about the middle one? All right, well, you guys remember what we talked about there. said, hey, if I'm going to have a half cusp relationship and I'm going to leave it, I'm okay with that. I just have to tell the patient why their teeth are this way, what's wearing, and what's going on. I could help align these teeth up a little bit better, but I'm not going to change that half cusp relationship in a situation like this. There's not going to be any AP correction. Great Monday morning case. What about this third one on the right? Well, wow, man, there's a lot going on here. I need to do a lot of expansion. It doesn't look like the arches really match. But guess what? Actually, we can get a lot of expansion and can get a bite like this to fit. We just need to have the skills to be able to do it and be able to manage it so we don't end up with a end-to-end relationship, edge to edge, anywhere when we're all done. Okay, so I think we got a pretty good basic understanding of what are good cases for us. We're going to look at that in more detail with the next couple modules. But right now, I want you to take all this stuff and put it aside because I want you to think of the steps and how easy they are for you to be able to do this. What do you do? Well, first you sit down with your patient and you recommend that they need to get their teeth straightened, and that will lead to a more in-depth consultation. May happen at the same time as your recommendation. And then also at the same time, you may take records or you may schedule to have the patient come back. At the records/consultation visit, you're going to want to make sure you cover some basics with the patient about informed consent so that they know about clear aligner therapy, what to expect, what contingencies could occur, how it all is going to fit and work for them. But once you've got records, now you're going to go ahead, you're going to build a treatment plan, and then you're going to deliver aligners. You're going to monitor the case, which is super easy. Wait till you see how easy it is. Then we're going to finish the case, and we're still not done because once we're finished, we've got to get them into a nice retainer system. Permaform is the one made by Candid and one of my favorites by far. It's got all these really cool features that set it apart from the other systems that are out there, and you're still not done. Guess what? We're going to come back here now, go back to the middle because we're going to monitor that retention. How long? Rest of their life. We want to make sure that we keep those teeth in the beautiful position that they're in so they don't move and we end up with something that looks really nice. You ready for a pop quiz? All right, here we go. Let's take a look at some cases and make just a determination Monday morning or not. Here's Jeff. Chief concern is my teeth are crowded. Jeff actually is an employee at Candid. He's the chief of staff for the entire executive team, and we say he's the Energizer Bunny. He runs things for us, front and back. And said, "Hey, it's time for me to fix my teeth. They're crowded." And I was like, "Yeah, man, I've been waiting to do that for a while because it drives me nuts." And as a dentist, it drives you nuts too. I look at this, I'm like, "Can I do this?" Wow, man, we've got class 1 occlusion. Love that. Narrow constricted arch. Hey, we're going to help him with his breathing here. Lingually inclined teeth. We know we can upright those without too much difficulty. A lot of crowding in the bottom, more than we see up top. Can I manage that? The answer is yes, I can. And he also shows the incisal wear thing we were talking about. So we're going to help improve that. Monday morning case. Yeah, treat this every day. This is a great case for us to get started with. We're going to really make Jeff happy. Excited to show you some other pictures of him, not just progress, but how he turned out. Absolutely gorgeous. How about this? Well, we got Susan here, and her chief concern was highly technical. I've got a snaggletooth. Her words, and if you look, she's got a snaggletooth. What she meant by that is that tooth number 23 was not only displaced because of crowding, it had made itself fit in there by rotating about 45 degrees. But good news is she's got class 1. Sorry, we don't show enough of a retracted view with these photos here, but we can get just that upper first molar, see how things are fitting together. Happy with that. It gives us an idea of what we want to accomplish, and one is not to have to change or move the bite. So I can rotate those teeth. I know that part of the issue is that she's got a Bolton discrepancy. There's too much tooth mass on the bottom compared to the top, and we have to do either some IPR or make some space up top and address it that way. Case we can do every day though, Monday morning. That's a Monday morning case. How about Stephanie? Her concern, and again, you're noticing that when I say concern, this is always in quotes because it's the patient's reason for coming in quotes of what they say. So chief concern here is my smile is worn. And when I talked with her about this, I was like, yeah, you've really kind of worn down those teeth. And she's like, no, not the edges. I'm looking at the front. You've been telling me about the edges for a long time, but now I'm noticing these things on the front, and this is that loss of enamel we talked about. There's so much flexure on those teeth that she actually has the equivalent of like abfraction lesions on the facial, as well as attrition, where the teeth have worn down on the incisal of the ledge. So she does have a worn smile, but she's class one again, looks beautiful. She had, if you look carefully, a tooth taken out in the bottom front when she was younger to help accommodate everything and make it fit together. They did a nice job getting everything to kind of fit, but she still has this envelope issue, reverse smile line associated with it, meaning that it goes upside down. Her front upper teeth, the central and lateral incisors are worn, which gives us that funky kind of look. It almost looks like you're always frowning. We can address that. We're going to line up the teeth and we're going to do some bonding to fix both the facial and replace some of the missing tooth structure from the wear. We're going to just pound out some bleaching for her to get rid of the tetracycline stain and see if we can make things look better for her. So Monday morning, yeah, you got it. This is an everyday case. Definitely want to treat it. Okay, and now we've got Mary, and we take a peek at this case. Her concern was, I have upper and lower crowding, and no doubt you do. You also recently lost a tooth that she fractured a root on. You can see it's actually in the Panorex, but not in the photos. So she had the number 14 extracted. Lingual inclination, good thing for us. We'll be able to help get those teeth lined up better. But she's got this class 2 bite, again, half cusp. And I went over things with her, said, we can fix that. Again, you can't getting started, but after you've got some skills underneath your belt, you can fix this case. It's just going to take some extra movement and some extra time to be able to get her into a nice solid class 1 occlusion. But getting started, not something we want to jump into right away. So this is more of an advanced case for us. Definitely not something I want you to dismiss, but once you've got a few underneath your belt, then you're comfortable to be able to jump in. Wow, great job. So happy that you're able to stay with us through this. We're done with module 1. We're going to let you take a break and then we'll jump back and talk to you about module 2 in just a bit. Thanks.